Let me just start my video as well. Oh no, that's blocked. Never mind, we'll carry on. Okay, so my name's Francesca. I'm one of the rheumatology trainees currently at St Mary's in Paddington. I am going to do a talk for you today on rheumatology, which I think would be helpful for your MRCP exams. I'm going to focus on the high yield topics, so autoantibodies, everybody's favourite. Identifying features of inflammatory disease and what you really should look out for in the question stems, and management of an acute hot swollen joint, which comes up frequently. And also then we'll just go through some key rheumatology conditions, so your inflammatory arthritis, your inflammatory spondyloarthropathies, connective tissue disorders, vasculitis, and crystal arthropathies. So starting with autoantibodies. So these are something that I would just really try and memorize for the exams. They're quick and easy marks. So starting with rheumatoid factor, this is present in a lot of cases of rheumatoid arthritis, 75%. And if you have any extra articular features in your patient, then they will almost certainly have rheumatoid factor present. It can also be present in the normal population. And something to be aware of, it can be present in other rheumatological conditions, particularly Sjogren's and lupus, but also can be raised in chronic viral conditions or liver disease. So just to be aware. Whereas anti-CCP is much more specific for rheumatoid arthritis and is present in around 70% of patients. And it's often associated with much more severe disease and often erosive disease as well. And it can be present for many years before patients actually develop clinical signs. You've also got your anti-nuclear antibodies, ANAs, and as the name suggests, they're directed against a variety of different nuclear antigens. We detect those using immunofluorescence, and the staining pattern that they give also gives an indication of the type of disease. So for lupus, you get homogeneous. Mixed connective tissue disease, you get this speckled type. Nucleolar, scleroderma, and then the anti-centromere is associated with Crest syndrome, and you get this centromere staining with that. And then if you're going to remember anything from this talk, I would just memorize this table because it does come up a lot in exams, and trying to link, you know, what disease do you think this patient might have, and then asking you to link the antibodies. So ANAs, one of the specific subtypes is double-stranded DNA, which is a type of ANA which is very common in lupus. So if somebody has double-stranded DNA, it's diagnostic of lupus. And you also have your extractable nuclear antigens, ENAs, which are a specific type of ANA. And you have all these different types. So anti-Rho and anti-LAR, think of Sjogren's, so those two together. And you also get anti-Rho in neonatal lupus. Then you've got anti-smooth muscle, which you often see in lupus as well. And people with that often get lupus nephritis. You've got your anti-RNP, which is associated with mixed connective tissue disease most commonly, but also lupus. And you've got your anti-Jo1, which is associated with myositis. And then these two, which I found very difficult to remember when I initially started, was the anti-toxinurase, which is also anti-SCLER70, which is progressive systemic sclerosis, and anti-centromere. And I know it's very basic, but I remember anti-centromere is that has a C in it, and Crest syndrome has C at the beginning, and that's how I remember it. So you've also got your anti-neutrophil cytoplasmic antibodies. So C-ANCA is associated with anti-PR3 antibodies. Now that's classic for GPA, so granulomatosis with polyangiitis, and we'll talk about that later. P-ANCA is associated with anti-MPO, and that's associated with eosinophilic granulomatosis with polyangiitis, so EGPA, and also microscopic polyangiitis. And just to be aware that you can get a positive ANCA without the presence of anti-PR3 or anti-MPO. And clinically, we often say that that's not significant. We only tend to care about ANCA if one of those antibodies is associated with it. And we use those antibody titers to reflect the disease activity as well. And it can help, you know, monitor the response to treatment and if a patient's relapsing. So then moving on to what should you look for in the history and the stem of the questions in patients with an inflammatory condition? So joint pains that are worse in the morning, whereas osteoarthritis, the pain gets worse towards the end of the day and with activity. Early morning stiffness. Now, it isn't just 10 minutes when the patient first gets up. Most people get a bit stiff when they first wake up as they get older. It's more if it's longer than 30 minutes. The pain often wakes people up at night, and it gets better with exercise, and that's particularly important for inflammatory back pain. The pain, unsurprisingly, will respond to non-steroidal anti-inflammatories and steroids. And then you also want to look for other features that they might give you clues that the patient might have psoriasis or inflammatory bowel disease, which are associated with obviously certain types of arthritis. Or they might have dry eyes or dry mouth, ulcers, rashes, etc., which might make you think of this as a connective tissue disorder. Then looking at hot swollen joints. So I'm sure you're all aware that if someone comes in with a monoarthritis, the first thing you should think about is this a septic arthritis? And you should always rule that out first. And you may have clues in the history and the questions. So is there cellulitis? Is there a joint prosthesis, which makes them at higher risk of infection? Did they get a bite from an insect, or are they heavily immunosuppressed? They all might kind of push you towards thinking this is more of a septic arthritis. And the treatment obviously would be with antibiotics. You would want orthopedics to be involved and consider a joint washout. Then other common things are gout. You can get a monoarthritis. So you want to look for the risk factors in the history. So have they got heart failure? Have they got a metabolic syndrome going on? Are they on diuretic therapy? Or is there increased cell turnover with psoriasis or chemotherapy that would increase your uric acid? And then the treatment for that would be your non-steroidal anti-inflammatories, colchicine or prednisolone in the first acute phase, and then with a plan to commence allopurinol. Pseudogout, you've got, it can present very similarly to gout. You might have a history of osteoarthritis. They might show you an X-ray with some chondrocalcinosis. And again, the treatment, although it's not as effective in pseudogout compared to gout, is the same. So it's NSAIDs, colchicine, and prednisolone. And then reactive arthritis, the clue will be that the patient will have had a recent either upper respiratory tract infection or maybe diarrhea and vomiting with a gastroenteritis. And you again would treat that with NSAIDs and steroids. And finally, inflammatory arthritis, don't forget, can present just with a monoarthritis, or indeed it can, if you're having a flare of your condition, then you might just have a single joint that's playing up. So then investigations just to consider. So obviously, you would want to make sure they're not spiking temperatures. You would want to get your baseline bloods, but also include urate and autoantibodies. You want to get x-rays of the affected joint. So is there that chondrocalcinosis that you see typically with pseudogout? Are there erosions which might suggest gout if they're a little punched out erosions? The key is to get an aspirate of the joint. So you want to look for an MC&S, rule out septic arthritis, but also crystals. And a key thing to learn for the exam, and I'll show you some pictures later, positively bifringent rhomboid crystals are pseudogout, and negatively bifringent needles are gout. And just really memorize that because that often comes up as well. So moving on to our key conditions, and I'm just going to really highlight the most important bits from each, and we'll go through quite a few. So rheumatoid arthritis, your pinnacle thing to remember is that it's a chronic symmetrical inflammatory polyarthritis, and it characteristically involves the small joints. It can be seronegative, so it may be anti-CCP and rheumatoid factor negative, just to remember. You can get soft tissues and extra-articular features as well. Other patterns of disease, you can get palindromic episodes where actually in between the attacks, the patients are super well. You can also get a systemic presentation with lots of extra-articular features, organ involvement, things like ILD or eye involvement. You can also get like a polymyalgic presentation where it may mimic PMR. It's more common in females, and there's an association with HLA, DR4, and smoking. So just talking more about the features, so you're looking at a symmetrical disease, and often the joints that are most commonly involved is the MCP, PIP joints, and that often comes up in questions that, the MCPs and PIPs are affected compared to the DIPs, which is more common in other conditions. Other joints can be affected, but that is the most common. And you're looking for those typical features of ulnar deviation of the MCP joints, the boutonniere, the swan neck deformities as shown in the picture you can see there on the right. You also can get tenosynovitis, and as I was talking about, you can get the non-articular manifestations. So neuropathies, a lot of them get carpal tunnel. Other features, so rheumatoid nodules, again, this only happens if they're rheumatoid factor positive. You get eye disease. And one thing to remember is that episcleritis is painless and scleritis is painful. And that may come up in the context of either this condition, other connective tissue problems, or if you've got to revise for other conditions as well. You can also get a vasculitis, and you can get pleural and pericardial disease, ILD, and Felty syndrome is something as well to be aware of, where you get this triad of rheumatoid arthritis, splenomegaly, and neutropenia, and often the patients are ANA positive as well and have other features. So just things to look out for on the x-rays that you will do. You may see just in the early disease some soft tissue swelling. You may see a little bit of juxta-articular osteoporosis. Then as the disease progresses, you're going to see joint space narrowing with cartilage loss. You're going to see bone and joint destruction and subluxation. Now, I hope that we don't see people like that as much anymore because of all the therapies, but you can still see older patients presenting like that. And then just thinking about treatment, so as a side note, we use a score called DAS28 to assess disease activity and see if patients are eligible for some of the treatments such as biologic therapies. But just starting off with the simple things, it's NSAIDs for symptom control, but often it's really important to note that they don't alter disease progression. So you need to start a disease-modifying agent as soon as possible. We love methotrexate, it's our first line choice, and it works by blocking dihydrofolate reductase. It's super important that you tell patients to take weekly with folic acid, because that reduces the risk of firstly side effects for them, like nausea, vomiting, GI upset, but it also reduces their risk of getting pancytopenia, hepatic toxicity, and pneumonitis, which are the most common things to be aware of with methotrexate. You also have your biologic therapies, which we give to people if they fail 2 DMARDs. I won't go into too much detail with those today, but the most common first line for most trusts is anti-TNF therapy, and we also are using rituximab more commonly as well. So moving on to your HLA-B27 associated disorders. So these are a group of conditions which are all characterized by the fact they're seronegative, and they can cause either an inflammatory arthritis and or axial involvement with spondylitis. So the peripheral arthritis is typically asymmetric, and it will involve larger joints, so the knees, the ankles. But other characteristic features to be aware of, you often get enthesitis, dactylitis, sacroiliitis. So it's just really important that you think about all of those different features, and things like uveitis, psoriasis, inflammatory bowel disease. There's a lot of overlap, and we'll go through some of the specific conditions. And there's this association with HLA-B27. Now, having that and testing patients for that does not necessarily mean they have the condition, but it makes them more at risk. And then this is just a little side note that inflammatory back pain, you're more suspicious in the history that the back pain is inflammatory if they're less than 40 when it starts, it's been insidious, it improves with exercise, and that the pain is worse at night with improvement when they get up and start moving. So ankylosing spondylitis. So this is characteristic for young men to get. They often have the back pain, which I described with those inflammatory features. And thinking about the articular features, so it's sacroiliitis, spondylitis, and they also can get a peripheral arthritis as well. And I like to think of the extra articular features as the 6 A's. So you have anterior uveitis, aortic regurgitation, apical lung fibrosis, aortitis, amyloidosis, and arrhythmias. And they're something to remember because you may get little clues in the question stem in someone with back pain, and you need to be thinking about ankylosing spondylitis. Diagnosis is normally just through radiological evidence. So we do MRI spines as our gold standard with the sacroiliac joints. And you don't often get an elevated ESR or COP. It may be mildly elevated. There's sometimes a normochromic anemia. And then we want to test for that HLA-B27. We use the BASDAI score to assess severity and help guide whether they need biologic therapies or not. But first line is NSAIDs. And just to touch on kind of the radiological findings and things that you should remember the most is that you can get these Romanus lesions on the MRI, which are these little erosions at the corners of vertebral bodies. You get that classic bamboo spine, and they might show you a picture of that, where you get the calcification in the spinal ligaments. And there's also enthesitis as well, often visible on the scans. Reactive arthritis. So this usually occurs around 1 to 3 weeks after an infection. So the common things that cause this are enteric, so post-gastroenteritis, got your Salmonella, Shigella, Campylobacter, after STDs, and also after upper respiratory tract infections like Group A strep. Now, it's different to septic arthritis. It's the antigenic material from the infecting organism that basically is identified in the joints rather than there being an actual organism there. So we don't grow anything if we were to aspirate the joint, and it doesn't respond to antibiotics. And you get that classic triad of arthritis, conjunctivitis, urethritis, so can't pee, can't see, and you have these other rare features such as aortitis and pleurisy and pericarditis. And that sometimes you can see this skin condition called keratoderma blennorrhagica, which is this picture on the side. I haven't ever seen that myself, but it's something to be aware of. And if you get shown that picture, it's a spot diagnosis. So prognosis, I mean, often some people do have the symptoms continuing for a while after they get it. Unfortunately, it's about 50% resolve, 35% people get better and then it happens again. And some people have this chronic disease and kind of turns into a chronic inflammatory arthritis. And so I call it the rule of thirds. And treatment is NSAIDs, sometimes steroids, but to be honest, they're not always that effective. So you may need to give them something like methotrexate or leflunomide. Psoriatic arthritis. So this is a polyarthritis, this you can have different patterns of disease. So you can have a polyarthritis which mimics rheumatoid arthritis but would be seronegative. Or you can have disease which predominantly affects the distal interphalangeal joints. And that's one way to differentiate between psoriatic arthritis and rheumatoid arthritis. You can get disease which predominantly is axial, affecting the sacroiliac joints and the spine, or you can have this asymmetric oligoarthritis. So you might have a knee or a hip or an ankle, and it's often, different on different sides of the body. And rarely you get this arthritis mutilans, which is that picture up at the top, which gets awful, destructive, erosive disease. And they call it telescoping of the fingers. Other features to look out for when you're examining patients is that nail pitting. So always look at the nails, and oncholysis, where the nail breaks away from the skin bed. And you want to look for kind of which joints are most affected, so that DIP distribution, and always examine their spine. The Caspar criteria, just so you know, is what we use for diagnosis. And treatment, like I said before, is DMARD, so leflunomide, sulfasalazine, methotrexate, and then if they're not working, then you'd escalate to biologic therapy. And anti-TNFs tend to be first line, and then we move to IL-17 and IL-23 antibodies. So next we're going to talk about lupus. So this is a multi-system inflammatory connective disorder, and it can affect any organ. It commonly affects young women, and there's increased frequency in West Indian populations. Clinical features, like I said, it can affect anywhere, but common things are skin rashes. So you'll know the butterfly rash, that malar rash. Often you can get discoid lupus, and a lot of the rashes are photosensitive. You get arthralgias, they tend to be non-erosive, and you can get fevers, mouth ulcers, hair loss. You can also get this serositis affecting the lungs and pleurisy, or the heart, getting pericarditis. And the thing you want to really avoid is lupus nephritis. It can be really nasty and life-threatening. It can manifest as nephrotic syndrome with predominant proteinuria. You can get glomerulonephritis. Patients can also present less commonly with neuropsychiatric issues, so with psychosis, strange behaviour, seizures. You get hematological changes, so cytopenias and autoimmune hemolysis, and there's also often an anemia of chronic disease. And that's the same for quite a lot of these autoimmune conditions. Raynaud's phenomenon is common, and then other things to just be aware of in these patients is myocarditis, and rarely an endocarditis, which is aseptic, and it's called Liebman-Sachs. So investigations for lupus, just to say that ESR is much more useful for reflecting disease activity. The CRP usually only rises with active disease of the joints or serositis, and otherwise may not rise. The way that we obviously diagnose is the double-stranded DNA is really important, and also if the complement is low, that's a big key indicator and diagnostic of lupus. And also we use those things in clinic to monitor disease activity. So if we see that someone's complement is dropping, then that's a worry that their disease is becoming more active. And we always test the urine albumin-creatinine ratio. We use something called the SLEDI score to assess severity, and that takes into account most of those common features and then common changes on the bloods. So this is just a diagram to show you that it can affect any organ and the most common things that patients can get. So thinking about treatment, so I tell all my patients to please wear sunscreen if they want to avoid some of their rashes, because it really can provoke the disease. Often we use NSAIDs for the arthralgias, and we start all patients unless there's a contraindication on hydroxychloroquine. It's really good at suppressing those arthralgias and trying to reduce the risk of flares, and obviously is steroid sparing. If that's not enough, we then escalate their treatment to azathioprine or MMF. That's particularly helpful if there's renal involvement. And there are other therapies if their disease is more severe and active. So we can give them rituximab, often 6 monthly, or belimumab. And then we use steroids for acute flares. And if there's life-threatening organ involvement, then you're looking at giving things like IVIG, cyclophosphamide, plasma exchange. Prognosis has got better, but there is a significant morbidity associated with cardiovascular disease. So we need to think about reducing those as part of our treatment. The 10-year survival is currently around 90%, and the main cause of death is due to active lupus with infection, and then the thrombotic diseases as well, and often there's an overlap with antiphospholipid syndrome. So next we're going to move on to dermatomyositis and polymyositis. So these are an idiopathic inflammatory disorder of skeletal muscle, and then when you get the skin involvement, it becomes dermatomyositis. So it can also occur as a secondary issue with other connective tissue problems. So you might get lupus with a polymyositis, or systemic sclerosis with a myositis overlap as well, just to be aware. And there is this association with malignancy. So with any patient that I see with either of the conditions, I would just screen them with a CT tap and even a PET CT. Clinical features are you're looking for proximal weakness, and that's really important. You're looking for if the muscles are tender and swollen. And obviously you want to assess all the muscles, not just the skeletal muscles. So they got any respiratory compromise with pulmonary muscle weakness, any swallowing issues. And then you also get an overlap with interstitial lung disease. You get joint pains, weight loss, and fevers. And then obviously, if there's any features of malignancy, you want to be looking for any of those red flags. With dermatomyositis, you can get the heliotrope rash around the eyelids, which you can see on the right-hand side there. Gottron's papules, which are these like violaceous raised areas over the knuckles. Get periungual telangiectasia, and you can also get these erythematosus macules. And there are certain other signs, so shawl sign, where you get this rash over the back and shoulders, and also round the front in like a V-neck sign. Investigations to be aware of. So we want to look for inflammation of the muscle. So you're going to look at the creatine kinase, the AST, and the LDH. You also want to do an EMG to look for abnormal signals. And the gold standard of diagnosis is a muscle biopsy and an MRI of muscles. So often we do the MRI of the thighs, might show you if there's edema there in the muscle suggesting inflammation, but also a site where you could biopsy. And then autoantibodies, which are often associated. So you want to do a myositis panel, and included in that are things like anti-Jo antibodies, and they're specifically associated with something called anti-synthetase syndrome, which is a subset of polymyositis. And you get things called, so you get mechanic's hands, which is this picture over here on the right. We get this very rough skin over the fingers, and Raynaud's, arthritis, ILD, fevers. And treatment for dermatomyositis and polymyositis, you want to be quite aggressive with the treatment. And we use steroids, so pulsed methylprednisolone, to get patients into remission. And you also need to give them immunosuppression as well. So if it's severe, and I've got a patient on ITU at the moment with dermatomyositis and respiratory failure, we've given things like IVIG, cyclophosphamide, and in other patients you can give rituximab. And then you're looking at things like azathioprine and mycophenolate to maintain the immunosuppression. So systemic sclerosis, this is another connective tissue disease, and this is characterized by the thickening and fibrosis of the skin. So that's the scleroderma part. And then you can get this distinct involvement of certain organs. It's more common in women. And the clinical features include Raynaud's phenomenon. So you want to particularly make sure that they're not getting digital ulcers and calcinosis. And they also get arthralgias. It can be erosive, arthritis. You can get the myositis, and I talked about that overlap. And very commonly, you can get interstitial lung disease and then pulmonary hypertension. So you want to screen all your patients with an echo and CT, high resolution CT of the chest. You also can get these renal crises where you get malignant hypertension with rapid impairment. And if you were to biopsy, you'd have this characteristic onion skin of the intrarenal vasculature. You obviously get the scleroderma, and you also have problems with motility in the GI system. So it can happen at any level. So it can happen at the esophagus, so issues with swallowing. You can have problems with absorption in the gut. And so you need to be asking patients about that. Investigation-wise, they might have raised inflammatory markers. Often they can be rheumatoid factor positive. They're almost always ANA positive, and you're looking for those anti-centromere and anti-toxoplasmosis antibodies as well, which are very specific. So the two different subtypes that you need to be aware of is the CREST syndrome, so the limited scleroderma with systemic involvement, and CREST stands for the calcinosis, the Raynaud's, esophageal dysmotility, sclerodactyly, and telangiectasia. The sclerodactyly is the picture at the bottom there. Lady's got very nice nails, but what it's trying to show is that you get this really tight, thickened skin over the fingers. And this condition, so CREST, is really associated with anti-centromere. So CREST, C, centromere, my pathetic little way of remembering. And CREST syndrome generally has a better prognosis. And also another way to clinically differentiate is that the thickening of the skin is limited to the face, neck, and the limbs distal to the elbow and the knee. Whereas in diffuse scleroderma, which has limited involvement, you have the scleroderma involving the trunk and the proximal and distal limbs and face. So this condition often starts with swelling of the fingers and arthralgias, and the renal crisis is more common. So you should look out for this even more in these patients, and always, be monitoring their blood pressure. It generally has a worse prognosis, and there's actually not a great survival rate. So 50% of patients have a 10-year survival, which I think is really poor. And the antibodies associated with this are anti-topoisomerase antibodies. And treatment, like I said, we need to be thinking about pulmonary hypertension, ILD, and that plus the renal involvement are the most common causes of death. Obviously need to monitor their blood pressure, their creatinine, and we generally avoid steroids because it can worsen the risk of renal crisis. And we often put patients on ACE inhibitors because that will help with the renal side of things. We, for the Raynaud's, will support them by giving things like vasodilators, avoiding beta blockers if they've got coexisting conditions, because that will worsen the Raynaud's. You might want to think about iloprost if they've got digital ischemia. So that's an intravenous infusion of prostaglandin, which helps to dilate the vessels. And PPIs are really important for all of those GI symptoms that I talked about. And then you're looking at immunosuppression again, because you don't want to give lots of steroids. So MMF, cyclophosphamide, and then obviously you would treat the pulmonary hypertension if that was present. So Sjogren syndrome is another connective tissue disorder to be aware of. It's characterized by lymphocytic infiltration of the exocrine glands, or I've put flans there, and it's particularly the lacrimal and the salivary glands that are affected, and that leads to the classic dry eyes, dry mouth, the Sicker syndrome. And often a lot of the autoimmune conditions can get a secondary Sjogren's. So patients with rheumatoid might complain of dry eyes, dry mouth, and there's often that overlap, or in patients with lupus. You get clinical features other than that. So talked about the dry eyes, dry mouth, but you can also get hoarseness of the voice, issues with the swallow. They can get vaginal dryness, which gives sort of painful sexual intercourse. You can have arthralgia and erosive arthritis, so you still want to be thinking about the joints, checking for lymph nodes. And I've seen some patients with horrendous parotid gland swelling, which they can find really like a horrible symptom, particularly young females. And you can get Raynaud's, neuropathies, renal tubular acidosis, and rarely pancreatitis. And so investigation-wise, the antibodies to be looking out for is anti-Ro and anti-LAR. ANA is present frequently, and rheumatoid factor can be positive as well. You also can look for polyclonal hypergammaglobulinemia. And something to really worry about in this subset of patients is that they're more at risk of lymphomas. That's something to be aware of. Treatment-wise, you can give them sort of supportive things like artificial tears, moistening sprays for the mouth, and then you want to give them things that will help with their arthralgias. So hydroxychloroquine is a gold standard alongside anti-inflammatories. So in terms of the next condition I want to talk about is vasculitis. Now, this is a big topic in itself. So this is a busy slide, but I just wanted to highlight that we classify vasculitis based on the size of the predominant vessel involved. I'm not going to talk about all of these today, but I'll talk about the ones which I think are most likely to come up. And then in terms of the clinical features to be aware of, so often patients will have those constitutional things, fevers, weight loss, fatigue. They often will have joint pains and muscle pains. You then are looking at specific organ vasculitis. So kidneys, a big thing to be aware of, respiratory symptoms. So often patients can get an alveolar hemorrhage, which is terrifying. Often they will have sinusitis, nosebleeds. You want to look for things like a mononeuritis multiplex and also cardiovascular disease, because it can affect the coronary vessels. They might get intermittent claudication and angina. You also want to look at the skin. So livido reticularis is that veil-like rash you can get over the lower limbs, sort of bluish purpley. And you can get vasculitic lesions, so the characteristic purpura. And treatment generally is you want to induce remission as quickly as possible with intravenous cyclophosphamide and steroids. That tends to be the most common regimen that we use. And then you can maintain them with things like azathioprine, MMF, and there are newer treatments coming out as well, which are antibodies against complement. So just focusing more specifically, so large vessel vasculitis, one of those subtypes is giant cell arteritis, which I'm sure you've heard of. It is the bane of my life. I get so many referrals for query GCA from GPs, and they're often, you know, just a migraine, but it's something that you should we want to rule out, because it can obviously have awful effects and lead to complete visual loss. So tends to be really rare before 50. So the mean age of onset is 70, and it's more common in females and Caucasians. You get this abrupt onset headache, and it's often unilateral with scalp pain, claudication, visual symptoms. And the visual symptoms you want to be really worried about is obviously the complete visual loss and the amaurosis fugax. You often get a constitutional side with fevers, weight loss, and there is this overlap with polymyalgia rheumatica. When you examine the patients, they might be quite tender over the temporal artery. There might be reduced pulsation. You obviously want to look at their vision, and the common things that you might see if an ophthalmologist was looking would be a central retinal artery occlusion. You get these pale swollen optic disc with hemorrhages. But it also makes it very difficult because lots of other conditions can cause that. So it can be difficult when you've got patients with diabetes and sort of hypertensive retinopathy. You also get extracranial involvement. So you always want to ask about limb claudication and check if they've got symmetrical pulses. We use the ACR diagnostic criteria often. So we want 3 of, you know, if they're older than 50, the headache is new, so they haven't got a history of migraine, etc. And you want to look for any abnormalities in the temporal arteries, and often we use ultrasound to do that. You want to look for the raised inflammatory markers, which is key. I've never seen one with normal inflammatory markers. And one way to diagnose is with the temporal artery biopsy, but you probably know about the skip lesions. So again, it's not always accurate. And often by the time we get a biopsy, unfortunately, patients have been on steroids for a while, and therefore it just becomes less accurate. Complications, you really worry about patients losing their vision, which is why there's the stress to start steroids early, and rarely you can get strokes, aortic dissections or aneurysms because of the inflammation. So treatment is starting high-dose steroids. So most trust it's either pulsed methylpred for 3 days if there's visual involvement, or 60 milligrams of prednisolone. If there's no visual involvement, and by visual involvement, for me, that means visual loss or amaurosis fugax. I'm not really fussed if it's a bit of blurring of vision. I'd rather put them on a lower dose. And we give them the steroids and then taper as their inflammatory markers improve. If we can't wean them, because they have got persistently high inflammatory markers or symptoms, we give them methotrexate, and also we're using tocilizumab now, which is an IL-6, anti-IL-6. We also give them low-dose aspirin to reduce the risk of stroke from the inflammation. So another large vessel vasculitis to be aware of is polymyalgia rheumatica. Again, looking at age over 50, a duration of longer than 2 weeks, typically shoulder and pelvic pain, and this typical morning stiffness and it needs to last sort of over 45 minutes. You have raised inflammatory markers, and you want to make sure you rule out other things like malignancy and infection as well, because often they'll have all the systemic things of weight loss and malaise. You give steroids, and again, you taper them according to the symptoms and inflammatory markers. And there's that relationship between PMR and GCA that's really important. So 50% of patients with GCA get PMR, and 15% of PMR patients will develop GCA. Takayasu's is really rare, but probably comes up in questions more commonly than we see it. It often involves the aorta and main branches, and it presents with arm claudication, absent pulses and bruits, and you get those systemic features like weight loss, etc. We diagnose it from angiography, and treatment again is with steroids. And then looking at the small vessel vasculitides, so you've got your GPA, which is what we used to call Wegener's, and that's characterized by this necrotizing granulomatous inflammation. And typically it involves the respiratory tract, both upper and lower. So you get sinusitis, alveolar hemorrhage, and you also want to really look out for any renal involvement with glomerulonephritis. And it's 90% ANCA positive, and it's C ANCA, so anti-PR3. And eosinophilic granulomatosis with polyangiitis, in contrast, is only associated with ANCA in 50% of patients, and it's MPO positive, and that's P ANCA. And it's associated with eosinophilia, and often patients may have a background of asthma. And you're looking at eosinophil-rich necrotizing granulomatous inflammation. And that typically, again, involves the respiratory tract, the kidneys, the skin, and you often get a mononeuritis multiplex as well. Microscopic polyangiitis is similar, but you don't get granulomatosis as the other two, but it is necrotizing, and you don't get as many immune deposits. You commonly get pulmonary infiltrates and alveolar hemorrhage, and often the skin's involved. And in contrast to EGPA, 70% are generally ANCA positive, and it's usually P ANCA, so associated with anti-MPO. So GPA is C ANCA, anti-PR3, and P ANCA, MPO, is EGPA or microscopic polyangiitis. And just a note on polyarteritis nodosa, I think the main thing you should remember is it's not associated with ANCA, and it's often associated with hepatitis B. So look out for that in the question if the patient's got hepatitis B. And then you'll be pleased to know we are nearing the end. It's a whistle-stop tour, but I've tried to cover as much as possible. So we're now onto the crystal arthropathies, and commonly that's gout. And so gout, as you know, is hyperuricemia, but you can have uricemia without having gout. Basically, you can get the acute crystal arthritis, where the uric acid crystals crystallize out into the joints and cause an inflammatory response. And typically this affects the small joints. The first, I was meant to say, MTP. And you can also get chronic tophaceous arthritis, where you get these lovely sort of gouty tophi in the ears or on the side of the fingers. And gout is now the most common inflammatory arthritis, in particular in those older than 60. And the way it works is uric acid is a breakdown product of purine synthesis. So it occurs because there's this imbalance in production and excretion. It can be primary, so there's some rare enzyme deficiencies, or it can be secondary, which is much more common. So you can get increased production of uric acid. So that's with your hematological malignancies, or if you're having a lot of purines in your diet, that's seafood and steaks and all the delicious things, and also anti-cancer therapies and psoriasis. Then decreased uric acid excretion, that's more common, and that can be caused by renal failure and your medication. So if you see diuretics in the question and there's a hot swollen joint, think gout, and also cyclosporin and aspirin. And alcohol is also a big one. So in terms of diagnosis, don't use the urate levels in an acute attack. They are often normal. The gold standard is to get a bit of fluid off and send it off for crystals. And you're looking for the negatively bifringent needle-shaped crystals. And that lovely picture there is some tophaceous gout. You can actually aspirate the tophi, which gives you this disgusting chalky type liquid, which you can send off and test directly for crystals too. Radiologically, you're looking for this punched out erosions if someone's had the condition for long enough, but you may not see that in acute gout. And then treatment. So we want to stop the inflammation with NSAIDs. Colchicine, although becomes less effective if the symptoms have been going on for 72 hours. And then prednisolone if the patient can't have NSAIDs or can't tolerate colchicine. It does cause quite a nasty diarrhea. Prophylaxis is super important, so telling them all the obvious things. So stop drinking alcohol, stop any medications that could be contributing, like the diuretics, and tell them to improve their diet and lose weight. You then want to start them on urate lowering drugs. Now, there's a discrepancy between guidelines from NICE and then the BSR, which is the British Society of Rheumatology. Some people say start them when they're in hospital with an acute attack, providing they've got anti-inflammatory cover, because if they get discharged home, often they then don't get started on it in the community, and then they just come back in with more flares. But other people say wait 2 to 4 weeks until after the acute flare. So there's a bit of discrepancy there, but you want to start allopurinol or febuxostat, which is xanthine oxidase inhibitors. And then we always want to aim for a urate lower than 360, and we titrate the allopurinol up and down to get to that level. And then you want to make sure that they're covered with anti-inflammatories whilst you're commencing the allopurinol, regardless of when you are starting it, because obviously any fluctuation in urate levels can precipitate a flare. And those pictures are just of your common places to look for in patients with gouty tophi. And then finally, crystal arthropathies also can also get something called CPDD, calcium pyrophosphate deposition disease. And this can present exactly like gout, tends to be in older patients and those with osteoarthritis and a lot of degenerative change. And it's caused by calcium pyrophosphate crystals depositing around the joints and then causing a secondary inflammatory response. Some patients are asymptomatic. You may just incidentally see that they've got this layer of chondrocalcinosis around the joint. You typically see it in the knee. Or they might present with pseudogout, often knees, elbows, shoulders. And you can get an inflammatory polyarthritis affecting the small joints, particularly of the hands, and that can mimic rheumatoid. Causes, so it can just happen, but it also is associated with things like hematomacrosis, Wilson's disease, hyperparathyroidism. And again, I've seen that in a question stem before where it's associated with someone with hyperparathyroidism, so just to be aware. And then treatment again is the same as gout, except you don't start allopurinol, so it's just, NSAIDs, colchicine, but often they sadly don't work very well. There's no evidence that prophylactic colchicine actually helps either. And then finally, this is just a nice slide showing the different crystals. So like I said, memorize that you've got your rhomboid, positive bifringent crystals in CPPD, and then your needle-shaped negative bifringent in gout. And that's it. You'll be pleased to know. So I think hopefully you've got some time for questions.
Hey, there are quite a few questions in the Q&A. Do you want me to read it out, or?
Yeah, no, I can see. Hang on, let me just, I'll start going through. So I'll just start from the earliest ones. Just wondering, often MRCP will give the normal levels. So when they give you the ratios, I think just focus on whether it's positive or negative, generally for the questions. The ratios, I don't think they will go into too much detail, but the ratio is just how we test on the immunofluorescence. So you're looking for the ratio of cells which have that change, basically, and how much you have to wash out before you stop seeing the change, basically. And then, do you have any methods to differentiate? So differentiating between the vasculitis, I think the easiest way of doing that is firstly thinking about whether there's C anchor or P anchor, as we discussed. So EGPA, you're thinking P anchor, GPA, C anchor. That's just quite a crude way of doing it. In terms of clinically, it's very difficult because they present similarly. So the most common things that I see is the respiratory and renal involvement, which they both can do. Again, you have the eosinophils, which is the difference, and also whether they've got asthma as their background, and that can differentiate between EGPA and GPA. How to recognize palindromic gout? Well, I guess gout is palindromic in the sense that most people get an acute attack and then it resolves in between. So you'll know about it because patients will suddenly wake up with a hot swollen joint and it comes on incredibly quickly. And pseudogout can present really similarly as well. So it's sometimes you can't differentiate until you get the crystal analysis back. And what DAS score suggests a flare? So we use DAS more to look at disease activity as a whole. So you then use it as mild, moderate, severe, and then certain scores will say whether someone's in remission. I can't remember the exact score off the top of my head because we always use like a website. We put in all the number of tender and swollen joints, and then it calculates for us with CRP. But around 4 indicates moderate disease activity. I think around like 2.7 or less is kind of in remission, and then high disease activity is around 5 or more is roughly, but you don't need to know DAS scores, I don't think, for MRCP. That's more something we use clinically. Why does RA not affect DIPs? Pathologically, I don't know. It's just how it typically presents. It always seems to affect the MCPs and PIPs more. And that's one way to differentiate it between things like OA, the nodal OA, where you get predominant DIP involvement, and also things like psoriatic arthritis, which more commonly presents with DIP involvement. So in terms of prognostic factors for rheumatoid arthritis, so anti-CCP is more of a poor prognostic factor than a rheumatoid factor. And other features we would suspect with rheumatoid factor positive RA. I mean, rheumatoid factor positive RA, so rheumatoid factor in itself, I wouldn't necessarily as like a poor prognostic factor. It's the anti-CCP. You're more likely to have extra articular features with rheumatoid factor, and in a sense that would then make you have more things to worry about, like ILD and eye disease as well. I'm just having a look at the next one. So this is a question about rheumatoid treatment. So You want to use things like steroids to get a patient into remission, but obviously you need to start them on a DMARD. We typically start things like methotrexate first, sulfasalazine, leflunomide, and you have to have used 2 DMARDs before funding is allowed for biologic therapy. And we generally start with anti-TNFs unless there's a contraindication. Just as a side note, anti-TNFs are more associated with TB reactivation. So you may pick a different biologic if you were concerned about that. And then after TNFs, you're looking at things like rituximab, tocilizumab, which is anti-IL-6. They're generally the next step you would go. I'm just looking at the next one. So this is another question about if they tried methotrexate and then they've had a side effect. So normally the next DMARD would be leflunomide, unless the contraindication was liver disease or something, because leflunomide also affects the liver. Sulfasalazine we also use, but in my experience, it's generally less effective and it's better used in combination with something else. And rarely you can get Stevens-Johnson syndrome, and I've actually seen that more than I would like to. It's quite scary, so I do tend to use leflunomide and methotrexate more. So this is a question about suspecting ankylosing spondylitis and their HLA-B27. The question is, would you do a pelvic and hip lower limb X-ray for sacroiliitis? I would say a lot of us don't bother with X-rays now. If you're concerned about inflammatory back pain, just go straight to an MRI, because otherwise you'll do the X-ray and you'll still then do the MRI anyway. AS causes amyloidosis. Like a lot of the autoimmune conditions, the chronic inflammation causes an increase in amyloid. Yeah, that's how it's just the chronic inflammation. And we see it in rheumatoid as well. Would you be able to show? I don't think I've got time to show you the radiological features, but I don't know if you get access to the slides afterwards, but there was some descriptions. The Romanus lesions, you're just looking for like a little punched out kind of erosion at the side on the MRI at the corner of the vertebral bodies. You often just look for things like bone marrow edema, but just type into Google, good old Google, and you should be able to see some. I think it'd be pretty mean if they wouldn't show you an MRI. I'd be surprised. I think it'd be more likely the old-fashioned X-rays with the bamboo spine and the syndesmophytes that they would show you. Yep, so pregnancies and DMARDs, sulfasalazine is safe, azathioprine is safe. You can't have MMF, you can't have methotrexate, and you can't have leflunomide, obviously. Currently, the biologics, they recommend that there's not enough data on the biologic therapies in pregnancy. I'd be surprised if there was a question on that because it's still kind of up in the air. Our argument is generally that if someone's disease is so horrible, particularly in the non-rheumatoid stuff, so if you're in the connective tissue disease stuff, if someone's got awful disease, you just want to make sure that that is adequately controlled. So it's a bit of a toss-up between risking the biologic therapy, and you might have an agreement with the patient that they carry it on until a certain part of the pregnancy, so maybe up until the 3rd trimester. And the same with like the JAK inhibitors and things. Does psoriasis come before the arthritis? So either or. So we can sometimes see patients have psoriasis for many years before they get joint pains and vice versa. And sometimes, you know, please remember that lots of people have psoriasis without any joint involvement as well. So hydroxychloroquine, this question is about lupus management. Hydroxychloroquine, we start all patients with lupus, any features of lupus we start. If there's renal disease, we still have them on hydroxychloroquine. It's just we then would add in azathioprine or MMF, or if severe lupus nephritis, you're looking at things like rituximab, cyclophosphamide. Leflunomide I've not seen used for lupus. Yeah. Oh, sorry, they mean MMF. Do you commonly give prostaglandins for Raynaud's, and what monitoring is needed? So generally, we start off with conservative measures, so core body temperature being warm, and gloves, etc., little hand warmers. Then we would escalate to things like calcium channel blockers. One of the problems is you get little crumbly old ladies that can't have anything that will drop the blood pressure. So then iloprost is a great option. We send them to the infusion unit and they'll have a one-off infusion of iloprost, or they may need several, but generally one can last you an entire winter. And it's really effective. And in terms of monitoring, we just monitor them whilst they're having the infusion. It can make you feel really dizzy and rubbish, so we just would slow the infusion down. How to identify an acute flare of lupus. So you can have serological flares in terms of you might see the complement dropping, the double-stranded DNA titers going up, which would make you worry. You can have flares where you start leaking protein and you worry about lupus nephritis. And the worrying thing is you can often have normal renal function with lupus nephritis, so it will just happen all of a sudden. So checking the urine is really important. Then clinically flares, so you're looking for worsening arthralgias, synovitis, worsening bouts of mouth ulcers, hair loss, like you've mentioned, pleurisy, pericardial effusions. You also want to look for things on the count, so are they becoming leukopenic, thrombocytopenic? And actually, if you look up the SLEDI score on Google, that's a really good way of remembering all the things that happen in a lupus flare, because it looks both at the bloods and the serology and also the clinical changes. Anti-Q antibodies. I don't think we've got time to go into that, but there are specific antibodies with myositis that are associated with specific cancers. So one to remember is anti-TIF. If you see anti-TIF antibodies, it's really strongly associated between dermatomyositis and solid organ tumours. Anti-Q is also one to remember, and that's, I think, ovarian. But I have to say, clinically, we don't tend to use those as much anymore. So you probably will know better than me in terms of being hot on that exam. Malignancy is associated with both polymyositis and dermatomyositis. I'd say there's a slightly more increased association with dermatomyositis, but we screen for both. So if I had any patient with either, I would just do a full screen. We don't tend to use Adelays. We use CK predominantly, and AST. Inclusion myositis. So patients will have similar symptoms, and technically inclusion myositis falls under an inflammatory myopathy. You'll see some changes potentially on subtle changes on the MRI, but the main way is muscle biopsy. That would be how you differentiate. And clinically, it'd be quite difficult to differentiate from like the muscle symptoms, but then you wouldn't have any skin association, you wouldn't have the ILD, etc. Just trying to skip through it. Why is systemic sclerosis associated with small bowel bacterial growth? Good question. I think that the increased inflammation, there's quite a lot of fibrosis and thickening, and I think that may give problems with the small bowel wall, and there's increased edema, then maybe more translocation and bacterial growth. That would be my guess. Yeah, so ACE inhibitors in renal crises are used as also as a preventer, but you're right, they may not be enough. So you can think about IV GTN and labetalol, but also you don't want to bring down too rapidly because of the stroke risk. So yes, sometimes the ACE inhibitors aren't enough, and you may need to think about other things, but the ACE is often, prophylactic as well. The treatments I mentioned are for both crest and diffuse scleroderma, so you treat in the same way. It's just that they have different clinical features, or you're more likely to get, for example, the renal crisis with diffuse scleroderma, and you're more likely to get pulmonary hypertension with crest. So it's just to be aware, but the treatments are the same. I'm not sure, this question's about a pharmacist not wanting patients to be on colchicine for too long. I don't really see why, unless it's because the patient wasn't tolerating it for the GI side effects. You can use it for the acute gout, but you can continue on for a while, as long as the patient needs it to settle them onto allopurinol and stop them from flaring. I often have patients who have PRN colchicine kind of pill in the pocket for when they get flares. It's not really, there's not a set time limit for it. Gouty tophi can be reversible, but you can get the very chronic tophaceous gout where then they start to not disappear. But in the early stages, I have seen them reverse. This is a question about how long to continue colchicine and NSAIDs when on allopurinol. Is it okay to start allopurinol straight after the first? Yeah, so this is what we were talking about. So NICE guidelines say that we should wait 2 to 4 weeks after the acute flare. And the BSR guidelines now state that we should be starting patients in hospital. And to be honest, I think we should be doing that, because we often write in the discharge summaries, please, can you start allopurinol XYZ, how many weeks after? And because of how stretched community is, sometimes that doesn't happen. And then we see patients coming in with repeated flares. So as long as the patient is covered with an anti-inflammatory of some sort, so either colchicine, NSAIDs, or PRED, it doesn't matter when they start the allopurinol. But for the purposes of the exam, it depends what guidelines they're using. And I probably would suspect NICE. So let's say 2 to 4 weeks. I've seen a senior doctor not give NSAIDs because of peptic ulceration and give steroids instead, but steroids also associated with peptic ulcers. Is this normal? So I tend to worry about both in the case of peptic ulceration, and I would give colchicine by choice, or I would give them an intra-articular steroid dose, so or an IM steroid, just to try and reduce the risk of peptic ulceration with things like oral prednisolone and NSAIDs. And obviously, please always prescribe a PPI with these things, but that would generally be my go-to rather than giving oral prednisolone. When to check urate after gout? Around 2 to 4 weeks. I mean, you can check in an acute flare, and it's still helpful because you can then use it to guide response, or like compare in the future. But obviously just be careful about the fact that you can't use it to diagnose it in an acute flare because it may be normal or lower. CPDD. Pseudogout is part of the CPDD syndrome, so spectrum. So pseudogout is kind of an older term that we use to describe a flare of CPDD, and often it's used in the context of a monoarthritis. So if someone's come in with a hot swollen knee or shoulder, etc., but it's part of the spectrum of CPDD. Febuxostat is generally second line. You can choose either, but we tend to go for allopurinol, unless I think the main reason that we use febuxostat is that you can use it with a lower renal function than allopurinol, but you cannot use febuxostat in heart disease. How long before you increase allopurinol? So my way of doing it is monthly. So If someone has got normal renal function, you start them at 100 milligrams of allopurinol, and then you will wait 4 weeks, recheck the urate. If it's still above 360, you then increase by 100. And you keep doing that every month, checking the urate before, and if it's still above 360, you add in an extra 100. If the renal function is less than 30, you want to give them a lower dose. So you would, sorry, when I say less than 30, I mean EGFR. You would give them 50, and then you would titrate in increments of 50, but in exactly the same way. Have we got time for more, or shall I stop?
Yeah, I think yeah, we've answered quite a few questions.
Yeah.
Hopefully our lectures are tailored to be quite high yield, so rather than going into depth, we're trying to cover more breadth, and hopefully we'll give you an opportunity for you to identify any areas where you'd like to read further into. But yeah, thank you for a great lecture, Francesca, and thank you everyone for coming. If you are still here, please, if you could fill in the feedback form, I posted it in the chat box. And hopefully we'll have more lectures in this series in the very near future. Otherwise, that's it for today. Thank you.
Thank you.
Bye.